2, 1. We are now live.
Thank you.
Good evening, friends. On behalf of Delhi Orthopaedic Association, I welcome you all for our third episode of Trauma Series. And the topic chosen is proximal femoral fractures. We all know that these fractures now are increasing day by day, maybe because of the aging population, and in youngsters also because of high energy trauma. And with better understanding of pathophysiology as well as newer implants, we are able to manage these fractures now successfully. And we have today three topics to discuss. The first topic is by Dr. Mukesh Jain, latest development in the fracture neck of femur in young. And we have Dr. Ritabh with us, who will discuss on tips and tricks of nailing in the IT fracture, as well as Professor Vivek will be joining us shortly, and he will be deliberating on management of femoral head fractures. These three topics have been chosen very nicely by our moderator, Dr. Samarth Mittal, and I welcome my esteemed faculty who have and thank them for sparing their valuable time and sharing their knowledge with us today. And I also welcome our DOA members and the delegates who have joined and will be joining for this seminar today. So I hand over now to Dr. Samarth Mittal for start the proceedings. Dr. Samarth, please.
Thank you, sir. Thank you, Atul, sir, for guiding us for this trauma webinar series. And I thank Dr. Ravi for actively helping in organizing these series of lectures. So today, as you have already detailed, that we would be talking about proximal femur fracture, and we have the best of faculty that one can get for these topics. And none of them need any introduction at all. So Dr. Mukesh Jain would be talking about latest developments in fracture neck of femur in the young. And I don't think there is any trauma surgeon who doesn't know Dr. Mukesh Jain. Then the next talk would be by Dr. Ritabh, and he would be talking about intertrochanteric and subtrochanteric fractures. And again, Dr. Ritabh is such a big personality in trauma management that I don't think anyone needs any introduction for him. And Professor Vivek Trikha will be joining us very shortly, who would be talking about head femur fractures. Followed by this, we would be having a few cases which will be presented by Dr. Sandeep Yadav, who is upcoming young surgeon doing a lot of pelviacetabular trauma and a lot of complex trauma. Dr. Nishank Mehta, who is an assistant professor in orthopedics at Trauma Center AIMS. And if there is some time left, then I would be taking up a case on one of these topics as well. So without wasting much time, I would now like to invite Dr. Mukesh Jain, sir, for his talk. Sir.
Thank you, Dr. Atul. Thank you, Samarth. And my thanks to all DOA that they have invited me for this talk. This is I'm proud of it that you have invited me. And my talk today is the fracture neck femur in young age, latest developments. As we all know, that every day in our practice for last 40 years, we never sleep with a fracture neck femur. Because you operate that patient after a month of follow-up, you see that whether it has united or there's a collapse or there's a shortening, so many things. So anytime you see a fracture neck femur, it is always a problem for orthopedic surgeon, especially in the private sector. So why do we need these techniques, new techniques? The reason for that, we have lots of failures. There are non-unions, we all know. There are malunions. There is a shortening of the neck femur, which is not recognized in the past, but that is one of the major complications that we have, shortening, and that because of that we have collapse, and that leads to ultimate shortening. And these shortening are the main cause for unsuccessful treatment for these fracture neck femur. Then we can have implant failure. Then AVN is we all know that this is one of the major complications of all fracture neck femur irrespective. And if you take the total complication rate is more than 30 to 60%. Now, what are the factors that affect this treatment? Low BMD, high BMI, old age of especially the female patients because they are osteoporosed. Fracture most of the time is a power 2 or power 3, they are displaced fractures. And many times you see the posterior combination, medial or posterior combination. And then there might be a poor reduction quality and implant is especially very important. Now, if you see that out of all these factors, only the poor reduction quality and implant is in hands of surgeon. He can have a good reduction quality. He should understand what is the good quality of reduction and then what implant he should use. The rest of the factors, they are not in our hands. Now, if you just see this X-ray, the 3 screws and the DHS, the fracture has united in the both sides. But if you see the shortening and the collapse, it is too much. And these patients are always unhappy. Now, if you take this article, which is from Norway 2012, it says there are 33% failed within 3 years of management. This is another report from Norway Hip Registry 2020. It said 10% needs almost revision in most of the cases. They have studied near about 134,000 cases, and out of that, almost 13,000 were revised. This is another paper from BMC 2016. 60 to 70 patients were unhappy after, say, 15 months to 2 years time. The reason for that was that the fracture has united, even they are unhappy. Either they're having pain or they are having limping. So these problems were always there, even after the union. So the problem is we don't want that neck shortening should not be there. It should be permissible up to 5 millimeter. If it is 5 to 10, we call it as a moderate. And if it is beyond 10 millimeter, it is not acceptable. Beyond 10 millimeter, patients are always unhappy. The second important thing, how to stop the neck varus, and then how to prevent non-unions. So these are the 3 problems which we are facing in the previous implants, that we cannot stop the shortening. We are not able to stop the varus, and there are non-union in 3 screws also, and non-union in the DHS also. So now there are different techniques they have come up in the last few years. And this is the Powell screw, which we all know. The only problem with this is that it can prevent the varus collapse and some neck shortening, but technically it is challenging. One. Secondly, it cannot be done for all the fracture of neck femur. Then we came about the medial buttressing plane. This is the open exposure of the fracture neck femur. You reduce it 100% and then put a posterior medial plate, which is a small plate like a fibular plate. So by this, you have reduced it properly. And after that, you can put your screws for the fixation, but it can prevent varus collapse. But not really, neck shortening cannot be checked. And secondly, you need an open reduction. And if there is a failure, then reopening it, it is a really tough time to take out the plate. So these are the problem with the medial buttress plate. Then came out of the biplanar screws. Now, this is quite common in our country that a lot of people are doing the biplanar and they're very happy. But the only problem is, again, there is a good published result in a small series, level 4. And technically, again, it is challenging. Thirdly, you cannot operate all the cases of fracture neck femur by this technique. So it is quite a difficult technique, very challenging. Then we thought that probably we can check by the non-parallel screws. So one of the screws was not parallel out of all these 3 screws. But again, the problem was there was inconsistent result depending on the fracture type and combination. And there was a higher rate of non-union in these cases. So this was not also successful. Then concept of intraoperative compression came. And this was, you apply a intraoperative compression during your surgery. And after that, you stabilize. You take out the leg screw and put a length stable implant like a full threaded screw. So this was a technique which has become very popular. And then what happened with this full threaded screws? See, what happened that there was leg shortening and loss of offset. So it was again an inconsistent result. There was a neck shortening. So in spite of using a length stable implant, there was a collapse. Secondly, Many times the screw has come out cut through, even in these cases. So this was again another demerit for this technique. Thirdly, we saw that there was a non-union in spite of the length stable implant. The reason was the two different implants and they are behaving very differently. And because of that, on one side there is a compression, on side there is a non-union. So again, with the DHS and fully threaded screws, the results not very good. After that, another thing came, the fully threaded screws and not parallel. So the idea was that you put the fully threaded screws, but don't put it parallel. But even then, there were a lot of non-unions. Then came the concept of the locking plate. And these locking plate, first you reduce the fracture, then you put an interfragmentic compression and then replace it with a lag screw, replace it with the threaded screw, and then you put a plate. And there were catastrophic results. And after open reduction and interface fracture neck femur, so it was not possible to use it, and it was almost came into the market and went out of the market. I think nobody's using nowadays. So dilemma, after going through all these things, what we need for fracture healing, we need some compression or some impaction. That is our first desire. That during surgery, we should be able to give some compression, number one. Number two, we need an implant which can prevent varus collapse, which is the angular stable implant. Like DHS is an angular stable, it is a very good stable implant, but it has certain problems with that. The third, we want that there should be no excessive neck shortening. So we need something which can stop the overshortening, which can control the shortening. So these three things are required to get a good result. So now is there any implant that meets these requirements? Yes, there are few implants in the market which has all these three things. Now this was the first, this came from S Club called Targon system. And this Targon system, the problem was that again, there was healing problems were there and it was not a good result after this. So it is not in the market at the moment. There were a lot of non-unions with this implant. There was high failure rate. Then came out with that we Conquest system. This system is again, it has own problems. It was difficult to insert and especially problematic in the patient with small diameter of the neck because these three screws are in different directions and it is very difficult into the shortening to put it in the right place. And plate most of the time is off. And that is another big problem with this implant, that plate is off the shaft. And then there was a fixed direction of these screws. So that become very different insertion, different challenging insertion. And that was also not successful. Now in 2017, Karl Stoffel, he's from Switzerland, he came with a very different idea. And that implant was called as fracture neck system, FNS. This is by DePuy, Johnson & Johnson. And this implant has this quality. Number one, you can provide an intraoperative compression of the fracture. Like you can see that, I just show you that after putting this implant inside, you use this just to fix the screw. This is a multifunctional screw. And then you just do the screwing on the clockwise direction. And you can see that now you can see this, it is going to be compressed. And now you can see the fracture line has almost disappeared. So that is the beauty of this implant, of this total instrumentation, that you can provide the required compression during surgery. Then second thing, we want something should be angular stable. And this implant is angular stable because it is a 130-degree barrel with this bolt, and then it provides a 5mm locking bolt. And this assembly is a very good as an angular stable implant. It is as good as DHS to prevent the varus forces, and to check the rotation forces, it is 1.5% extra to the DHS. So it is a better implant than DHS to check the rotation, to check the varus. Then, so the third thing what we want, we need something which can provide a continuous compression, but we can prevent the shortening also. So if we can control the shortening, I think our purpose is served. So what we need a compression, we need an angular stable implant, and then we need something to control the short neck shortening. And for this, the beauty of this implant is that you can do a pre-collapse technique. You can use a longer bolt and pre-collapse in advance. And when you put it into the fracture neck femur, then your shortening can be controlled either 5 millimeter or 10 millimeter or 15 millimeter, whatever you desire. So this implant has all three things which it is fulfilling. So FNS is ideal for treatment of all fracture neck femur, whether it's a power 1 or power 2 or power 3. It is an angular stable implant. It can provide you compression during surgery. It can control your rotation and it can control your collapse. So FNS is ideal to fulfill at all the requirements for a fracture neck femur treatment. Now, I will just show you a few cases. This is 43 years old male who came to us after 3 days. And this fracture was a transcervical fracture, comminuted, power 3, garden 4. Now, you simply need your reduction. And after reduction, you can put a central guide wire. That is the only wire which guides you everything. Once you put your guide wire centrally in an AP and lateral view, your surgery is almost done. And on that screw, on that wire, you can drill out your bolt for the bolt. You put the bolt and just put your lock screw. That is all what you need for a FNS. Now, this is the follow-up after 1 month. You can see there is no shortening, there is no collapse. And this is the follow-up after 4 months. There was a moderate collapse, but fracture is united. Offset is maintained. And this is the patient. You can see the walking after 4 months, almost absolutely normal with a power 3 fracture. Now, this is another case, 30 years old female who came to us after 3 days, power 3, garden 4, basal fracture neck femur. Again, the FNS was done after achieving a proper reduction. And this is after 1 month. There was a very little collapse after 2 to 3 millimeter. Offset is still maintained. And if you see the post-op after 3 months, that almost the fracture has completely united. There is no further collapse. There is no further shortening. And this is the patient. After 2 months, you can see the patient is walking almost normal without any stick, without any support. Now, this is another indication. This is a patient who is 64 years old. Now, this is the extended indication for the patient or old age group, but it is only meant for power 1, where you have an impacted neck fracture. If the patient is above 65 or 60, which looks old, and if it is power 2 or power 3, this implant is not indicated. Then you have to go for a replacement. Now, this patient is having a power 2 type and a garden type 1. Now, if you can see, there is a valgus impaction. And another thing is there's no retroversion. That is very important. If you see this retroversion in these fractures, even in the garden 1, there is no indication for this implant. Any patient at the above 60 age, which is the impacted fracture, and if in the lateral view or in a CT scan, you see that there is a retroversion, please don't take this implant. So again, the FNS was done. This is final post-op X-ray. This is after a month. Even within a month's time, you can see the fracture is fully united. This is after 3 months. No appreciable collapse. Even the patient is 64 years old. Even then, there's no collapse. And you can see that the patient is absolutely fine after 3 months. He's walking without a limp, without any shortening. Now, this is another patient who is 75 years old male. I operated for a PFL last year. This time, he again came with a fracture, which is almost a trochanteric line fracture, which is a simple fracture. I thought that we go for FNS. So first we did a perfect reduction and then a guide wire, central guide wire, and then FNS. And this is final post-op X-ray. You can see that this is fracture and this is the FNS. Fracture is perfectly reduced. And then you see that after follow-up 3 months, the fracture has fully united. So after seeing these X-rays, you can make out that this FNS is so good that most of the time it is successful if you have chosen the right indication. If you have done your workup properly, the size of the bolt is very important. Placement of the screw is very important. If you know all these things, I think this is a very successful surgery. Now, if you think about few complications, since it is a very new implant for last 3 years in the market, only we have some experience with the Japanese and Chinese. And this is the first paper of 7,400 cases from Japan. And this paper has shown that there was subtrochanteric fractures, there was a cutout, there was a varus deformity, difficulty in distal locking, displacement of head, AVN, shortening, rotation, non-unions, implant failures. I'm not talking about the AVN, all these cases, but what they have shown that out of 6,000 cases, there were milder complications in 179 cases. So almost 2 to 3% complications were there. And all these complications, when I saw all the X-ray, I thought that the indications were quite extended. They have not done the proper indication. And secondly, they are putting the bolt and the screws were not in the proper position. And I think that was the reason for all these complications. Because we are a learning process, so we have improved the technique a lot. Now the complication rate is very minimum. Now, if you see, the problem was the subtrochanteric fracture in these cases. And this was all because of the effect of the plate position was not proper. So what they were doing, if you just see, the plate was not into the center. It should be along the axis, but the plate was eccentric. And probably when you put this screw, you have lost your cortex, so the posterior cortex and anterior cortex, and probably that was the reason of the fracture. Now you can see that this is quite out, and it is the eccentric placement on the CT scan, and this is the reason that he had a fracture for this. So it was not the implant which was responsible for the fracture. It was all because of the malposition of the plate and the screw. Another fracture, again, the same FNS was used. Again, if you see, again, it is the eccentric position, and there was a reason that it has come out. And you can see that this has come out. And again, this was because the patient was 83 years old. So this was not a right indication for FNS. It should have gone for a replacement. The bones are quite osteoporous. You can see the diaphysis. There is no cortex in the posterior side. So this was not a right case to choose for a FNS, and that was the reason for the complication. Another problem was the difficulty of the screw removal. I think it was again because the screwdriver which has been provided to put this screw is not very strong to take it out. So nowadays, what we do, we use the same screwdriver which is used for the putting the implant, but we use a separate screwdriver which we already using for other screws to remove, like a normal screws. So then it becomes much easier to remove. And second important thing which we have noticed, that if this tip is not beyond the cortex for 4 millimeter, if it is inside, then there are chances that you will have a lot of callus formation around, and it becomes strong and it will become difficult. So nowadays, what we do is we put 4 to 6 millimeter extra. So then it becomes much easier. So the idea is, if there is a problem in removal, use a good screwdriver, and your screw should be always a little bit lengthier. So to summarize about this paper, they've done almost 7,500 cases in Japan. There were 2.8% complications other than AVN, which has not been mentioned, which we don't know, and we don't have any control on that. But still, we have to watch that what is the change in the AVN after using these implants, because especially if you compare the 3 screws versus DHS, the AVN in DHS is much higher than 3 screws. And the reason we all know, when you are putting a DHS screw in a strong bone in a young patient, there is always a torque. And this torque leads to spinning of the head. And that spinning of the head stretches the capsule. And that can cause damage to your vessels. And that becomes the cause for the AVN in the future. So keeping that thing in mind, probably this implant is much better because there is no torque on the head. And we hope that the AVN rate will also go down. So always pay attention in plate position, which is very important. Anterior plate position is not the right position. You have to have true lateral view to check it. And then indications are very important. You cannot go in the all osteoporous patient, even in older age group, if it is a power 2 or power 3, or there is a retroversion, you cannot choose this implant to use them. And thirdly, your bolt size of the implant should be absolutely perfect. Always try to go just close to the head so that you can have the bigger implant to get a better stability. So, and another thing is there is operation time is hardly for 15 to 20 minutes even for a beginner. You have a very less radiation exposure. There are very less complications, less shorting and better hip function. In 2 years, almost we started in September 2020. Now it is almost 18 months. We have done almost 40 cases. And believe it, all 40 cases luckily have survived, good union. There is no collapse and there is not much shorting. I think all the patients what we have operated so far, they're all happy. I'm lucky. I'm just waiting. Any day anybody can come for AVM. But the union is almost done on all the cases. Thanks a lot for patience sharing. I'm sure that it will help the newer generation to understand the fracture neck femur and to use the better implants. Thanks a lot.
Thank you, sir. Thank you, sir, for that comprehensive talk on all the modalities of fixation and telling us about the pros and cons of each modality, and then explaining this newer implant in the market and the advantages that it has. So we have a few questions. One question is, sir, being an angular stable implant and a good hold into the neck, do you think this has a role in earlier weight bearing than the other implant options that we were using in the past, like a DHS and a derotation screw?
I think the concept of weight bearing should be clear to everyone. You see, any fracture which is stable to begin with means power 1, whether he's a young patient or an older patient. And you use any implant in a stable fracture, you can walk, full weight bearing. Very simple. If it is power 2 and power 3, they are unstable fractures. Means you cannot walk on them. So there's no question, irrespective of DHS or FNS, that you can start weight bearing on day 1 in power 2 and power 3. So always think what you are treating. If you are treating power 2 and 3, no weight bearing, only toe touch. If you are treating power 1, whether it is a young age or old age, full weight bearing. Clear?
Thank you, sir. Sir, another thing is with the new reports coming up of FNS being used in undisplaced, not displaced, but undisplaced neck femur fractures in any age, even in people beyond 65, like you pointed out, it should not be used. But now newer reports are coming up even in 90-year-old patients with stable power 1 undisplaced fractures of the femoral neck. Do you think there is an indication where these should be tried, or these patients should be directly be treated with a replacement?
I will say they should be replaced. Only indication is the impacted fracture, which is stable in nature, and that too if there is no retroversion. These are the only indications for me for FNS. Otherwise, you will end up with problems. So don't blame FNS.
Thank you, sir. And another question we have is, what do you think about the learning curve with regards to this implant? Would it affect practice, and is some form of training essential before using this implant?
I think it is only the understanding of the implant, and the most important understanding is the proper reduction. You should know how to take the proper lateral view. 2, and third, you should know what is the pre-collapse technique. Once you understand these concepts, I don't think that this is any problem. It's a very simple operation, very easy to learn for anybody. So there's no question about that you need a lot of time to learn it. Hardly if you do 3-4 cases, I think that is good enough. After reading a good book, reading all about FNS, I think anybody can do that.
Do we have any other questions from the panel?
Hi, Samarth.
Yes, sir.
I have a question. Dr. Mukesh Jain, sir. I have a question that do you think that we have to really change our practice from CCS to FNS?
See, no, it is not that. See, you have to understand what you are treating. See, if you are treating a power 1, you can use any damn implant. Whether you use a DHS or you use the FNS or you use 3 screws, you will be successful. If you're treating power 2 and power 3, you have to be careful. if a patient is young and the bones are stronger, you have seen the complications of DHS. I think FNS is much, much better, far superior. And if not today, we will change in our practice in coming years.
Okay. Another question is that do you really think that it is a cost effective in terms of if the patient land up with the non-union or other complications with the other implants, and doing this FNS in a patient with a type 2 or type 3, it will be cost effective overall to the patients in terms of later complication and management?
You see, I take it in a different way. If you treat 20 patients of fracture neck femur in a year, how many goes for the complication? Let us presume out of 25 goes for complications. And I can assure you, if you use FNS, probably one may get complication, and that too because of our experience, poor experience. Once we know the implant, once we know the technique, probably we will definitely reduce the rate of complications. And if you just see now economy, then you will be using FNS.
Okay. Thank
you, sir.
Thank you so much, sir.
Ritabh sir, what is your take on the FNS, or do you have the same experience?
I have never done it so far.
Okay, sir. Vivek sir, your comments on the FNS, sir?
Thank you, Samarth. They are mostly the same as what Dr. Mukesh Jain has said. I can definitely say that FNS will change the practice of most of your surgeons who want that the fracture at the patient's neck should be saved and salvaged rather than replaced. We have been doing it with DHS. CC screws are only there for Powell's 1. For Powell 2 and 3, you definitely need a stable implant. And I feel that FNS has changed it. Yes, you cannot have control over avascular necrosis, but the compression which you get here, the swiftness and the time of the surgery, which is so much reduced, technically it has definitely improved the results even in the younger age group people who were doing it. But let's not forget one more important thing, which is reduction. Once you have got that reduction, FNS is the best implant right now, which is available for maintaining that reduction and getting that compression. But that premise is we have got the reduction which we want.
Thank you, sir. So I think with this, we move on to the next talk on nailing in intertrochanteric fractures by Ritabh sir. I request Mukesh sir to please stop sharing the screen. Ritabh sir.
Yes. Hello, Dr. Vash, and thank you, Samarth, for the very generous introduction. And thank you to DOA for giving me this opportunity to share my thoughts on intertrochanteric fracture and what I have learned through failure of my own and others during my journey so far. We all know that 13 years ago, this article in JBJS gave us the 10 golden rules or commandments of doing nailing in IT fracture. If we look closely at these rules, if there is no lateral wall, there should be no hip screw. So the idea was to recognize the unstable pattern. So point 2 and 3 are more or less the same. Similarly, if you keep the anterior femur bow in mind, keeping this condition in mind, it was advised that one should be careful of the nail trajectory and not hammer the nail in to seat it. Otherwise, there could be some problems, which I will discuss in the upcoming slides. So point 4 and point 7 too are common. Similarly, reaming a reduced fracture and avoid varus angulation. Basically, again, highlight the importance of the reduction, which Dr. Mukesh Jain sir said, and Dr. Vivek to re-emphasize that reduction is foremost. So these were the 10 golden rules. And over the years, adopting these, I have learned a few tips and tricks through trial and error and discussion with colleagues and people like Dr. Mukesh Jain and Vivek. So when we have an obese patient, and there is no dearth of high BMI patients nowadays. The question is, where do you give the skin incision? So what we do is, after cleaning and draping, we mark out the tip of the greater trochanter on the skin under the C-arm. And in the lateral view, we mark out the direction of the femur canal as is shown. And these are the kind of skin markings that we get. So you can see that I have labeled the line as the tip of the GT as the GT. And then there is a 7 centimeter mark in the thigh marking the origin of the fracture, the start, proximal and distal end of the fracture. And the skin marking proximal to the GT, 5, 10 and 15 centimeters. So the bulkier the patient, the higher the entry point must be. Sorry. So if you see in this particular patient, the guide wire went well at a point 15 centimeters proximal to the GT. If we go acute, if the incision is lower than this and we make an acute entry point, as you can see in this case, what happens is, as the nail goes in, this is what will happen. The nail will go in, but the bone will give way. So the idea is to come in line with the femur canal, and the bulkier the patient, the higher one should enter from. The honeycomb is a very good tool to move medially. And the more medial we move, the less chances of error. Coming to the nail selection, should it be a 130 degree or a 125 degrees? DHS all we remember were 135 degrees. But as our population is aging, the neck shaft angle is reducing. And currently the recommendation is that we must err towards using a 125 degree nail. So as we can see in this example here, the native angle on the right side of the patient is 125 degrees. It was a subtrochanteric fracture that was plated. Unfortunately, things didn't work out. As you can see, the native angle is 125. And that is what we did. We subsequently revised this using the 125 degree device. And we were able to go center. What is the problem if we use our 130 degree nail in a 125 degree neck shaft angle? So what we end up with is something that you can see on the medial side in the calcar region is an open calcar reduction, something like this, which I call an open mouth reduction. So it is good as long as we can compress the fracture, which I will come to subsequently. Coming to the entry point, there are a wide variety of nails imported as well as Indian, and our patients are equally different in their anatomical profiles. So what we do is, once the fracture is reduced on the fracture table, we take a shoot of the C-arm with the implant we have and put it on the anterior part of the thigh as is shown. The proximal end of the nail gives us an idea of the correct entry point for this patient with that nail that we are intending to use. And if we have to make an error, we must move a little medial. So this is known as the onlay technique. Coming to the entry point in the AP view, it is also important to see it in the lateral view. So in the lateral view, there are two lateral views, one which we take at 90 degrees and one which we elevate the C-arm by 15 to 17 degrees, which is known as the true view, when the shaft, neck and head are in the same line. So the idea is that the guide wire should be in the center of the shaft, as is seen here. After the entry point, the next important tip which I have learned over years is the trajectory of the guide wire. So as you can see here, a fracture has been reduced and held with 2 K wires, and this is the entry point in the AP view. It should be parallel to the lateral cortex. If it is not parallel to the lateral cortex, there are going to be problems. Trajectory in the lateral view, again the guide wire after the correct entry should be parallel to the anterior cortex. If it is not parallel to the anterior cortex, even with a correct entry point, if we make an eccentric trajectory, the proximal fragment will end up in flexion. which is the most common error. Now, coming to the wedge effect. Essentially, a nail is driven in through the fracture. As you can see in this case here, the proximal end of the nail having a dimension of almost 16 millimeters is keeping the fracture ends apart. So this is known as the wedge effect. So why does this happen? The fracture is entering through the nail is entering through the fracture, and as we push in the nail, it tends to tilt the proximal fragment into varus. An example here, you can see that the length of this line on the normal side, when extrapolated to the opposite side, it shows that the proximal femur morphology has changed. The abduction axis or the lever arm has actually increased. This fracture is in distraction. It may still go on to unite because the hold of the spiral blade is good and it gives bone enough time to heal. But the morphology is altered, and like Dr. Mukesh Jain sir alluded to, the fracture may unite, but the patient would still walk with a limp. So the idea is to remove the lateral portion of the proximal fragment. This is the hard piece of bone in the proximal femur, which can push the proximal fragment into varus. So this is how it is done. The first guide wire need not necessarily enter the femur canal. It should just abut against the medial cortex, and we remove the hard bone with the reamer inserted just up to a centimeter or so in depth, and then subsequently go ahead and do the kneading. Coming to this radius of curvature, I have written the radius of curvature of the implants that are standardized and their dimensions available on the internet. If we see, the latest Synthesis implant has the least radius of curvature, 1 meter. Most of the Indian implants that we have used have a radius of curvature greater than 2 meters. So what does this end up doing? This is a TFNA implant and this is our Indian implant. So the longer we go, the higher the chances of the nail hitting the anterior cortex. So we must be aware of this and not hammer in the nail. Coming to the position of the lag screw, it is desirable to have it center. It is not always possible because of the different morphologies. And the moment the lag screw goes eccentric, the rotational forces increase and there is a chance of loosening. So failure begins by rotational loosening. So you can see that the position in the lag screw on the left is not in the center. The reduction may be good, but the choice of implant is good, but the position of the lag screw is not good. Vis-a-vis the opposite right side, center lag screw position. And this is what subsequently happens. It's a cutout. And then we had to revise it. So it was a technical failure on our part. Despite a good reduction, we did not ensure a center position. Compression across the fracture site. The beauty of the FNS system that Dr. Mukesh Jain sir alluded to was compression. This compression enhances fracture margin interdigitation. The moment the fracture margins interdigitate, it enhances the rotational stability of the fixation. And the beauty of this compression is that it is controlled by the surgeon. Seen on the lateral view, you can see the compression. So in all proximal hip fractures, neck, femur, and intertrochanteric, usually it is the anterior cortex that is left virgin, that is left unbroken usually, because it's a failure in tension. Medially, the lesser troch pulls off, and posteriorly you have comminution. So if the anterior cortices can be made to touch each other and compressed, it reduces the load on the implant significantly. Now we have done all well, and we make the patient weight bear. So what happens is there is dynamism in the system. The dynamic hip screw, the same principle left to the proximal femur nailing. So this compression that occurs on weight bearing is known as impaction. Yes, it is desirable to a certain extent, but when it starts impacting, the risk of fixation failure is not there. But the proximal femur morphology starts altering. The fracture may unite, but the patient will not be happy. So this is a backing out, as is shown here, and this is a backed out. So can we avoid this? The answer is yes. Now, this is unpredictable, and can we avoid it? The answer is yes. Another example of a screw collapsing. So when impaction crosses a centimeter, it is known as collapse, and collapse is akin to failure of fixation. This is a blade which has collapsed. The reduction is looking very good on day 1, and at 3-week follow-up, you can see the collapse occurring. The lag device is backing out, proximal femur morphology is changing, and the patient may not be happy. So compression is controlled by the surgeon and is desirable. Impaction is beneficial but largely avoidable, and collapse is the least desirable. So here comes the concept of locking the lag screw. So once we have reduced the fracture like Dr. Mukesh said and Professor Vivek have said, reduction. Once we have reduced the fracture, if we can compress it and maintain it, 90% of the job is done. So once the fracture is reduced, compressed, the best way to avoid further neck shortening is locking the lag screw. The demerits of locking the lag screw, if we have not done a good job, we are blocking further impaction and collapse and risking the chance of failure. If we don't lock the lag screw, the fracture may unite, but the proximal femur anatomy would remain distorted. So locking the lag screw definitely helps in the more unstable patterns. So the take home, what I have learned over years is reduction remains paramount. And what we mean by reduction is across the 360-degree circumference of bone where the fracture has occurred, there has to be at least a 90-degree arc of bone contact between the two opposite sides of the fracture. Know your nail and its dimensions and its specifications. The precise entry point is crucial in both the views. The trajectory is the next important step. Once this is done, lag screw position and depth is vital. So spend more time on this, and controlled compression across the fracture will always help. Thank you.
Thank you, sir, for that wonderful talk covering almost all aspects of intertrochanteric fracture fixation. I have a few questions for you, sir.
Yes.
Sir, you mentioned about the curvature of the nails and how different nails in the market are coming up with different curvatures and how one nail has a better curvature than the other. But
Right.
it may not be possible in everyday practice to use a single type of a nail because of so many other constraints. So
Yes.
is there any trick to use a nail with a lesser radius of with a higher radius of curvature and to avoid anterior impingement while putting a long nail?
See, the benefit of a long nail is only one, which in my experience, if we use it in a normal routine fracture, is most of the patients are elderly and they may fall down again. So if nature has given us an opportunity to fix this bone, fix the bone, given insurance that this does not happen in future again. That's the first merit which I feel. Yes, there are strong indications for using a long nail, an unstable pattern, a reverse intertrochanteric fracture, or a subproc. But routinely, I prefer to err on the side of using a longer nail to prevent a refracture occurring because the elderly will fall down. So if in case the patient is short, the femur is bowed, rather than giving the patient a complication, err on this side of using a shorter nail.
Thank you, sir. And your thoughts on the use of an end cap in the nails, because I saw in most of your X-rays the end cap was not there.
We don't use end cap. Two reasons. It costs 1,500 to 2,000 rupees extra. These are put in elderly patients where we don't think we are going to remove them ever. Third reason, most of the nails, if you see, remain a little proud. because the femur and anatomy morphology of a patient is lesser than the average Westerner. So the nail is already proud. So adding an end cap with its value probably does not make sense to me. I'm not intending to remove this.
Thank you, sir. Any other comments or questions for Ritabh, sir? Sir, your thought on reduction, sir, between a positive reduction and a neutral reduction, what form of reduction would you prefer in reducing these intertrochanteric fractures?
Right. Just for benefit of our younger audience, Samarth has said positive and neutral. So when we see the reduction in the AP view, if the inferior spike of the proximal fragment is medial to the shaft, that is known as cortex positive reduction. If the proximal fragment calcar and the distal fragment calcar are in line, that is known as negative. That is known as neutral. So if I show you this X-ray, this is looking like a neutral, Samarth. This is looking like a neutral. But why has this impaction happened? Because of something in the lateral view. So this is known as cortical neutral. And if we see this, this is known as cortical negative, where the spike of the proximal fragment is lateral to the distal fragment. So not only AP, when we see the lateral view, there is something known as cortical A and subtype P. A for anterior and P for posterior. So if the proximal fragment is anterior to the distal, that is subtype A, anterior, that is desirable. So why this has happened in this particular patient is, I'm sorry, I didn't show you the lateral view. This is in a lateral view, a cortical subtype P, where the spike of the proximal fragment was actually not in line with the shaft, but behind it. That has allowed this impaction to happen. So I would prefer, if I'm making an error, towards A or neutral, definitely not a negative cortical reduction.
Thank you, sir. And sir, another question we have is, how do you choose, because the nail that you are using has option of both a blade and a screw. How do you select when to use a screw and when to use a blade?
Right, good question. So I would like to get a feel of how good or secure the hold is. So a screw gives me a better feedback of the hold. So I always err on side of using a screw. As long as the screw is in the center and I am happy with the hold, I would prefer using a screw to a blade. As I can tighten the screw right up till subchondral bone. A blade, on the other hand, has a sharp advancing edge, and it is recommended to stay at least 8 to 10 mm away from the joint in a blade. But with a screw, I can go up to 3 millimeters subchondral. So I err on side of using a screw.
Thank you, sir. We have a question from the delegates. What is your view on the use of nail in stable intertrochanteric fractures instead of using a DHS in these fractures, sir?
Right. Again, a good question. As our practice has evolved and we have become more and more confident and comfortable in a surgical technique, our results become better. So if the intertrochanteric fracture is a stable one, and since I'm more comfortable using a nail, I can do it much more effectively, much more efficiently than a DHS. A DHS is equally capable of doing it at far less the cost, which is perfectly justifiable. But in my practice, I have switched to nailing because it gives me a better feel of giving confidence to the patient. That's my take. It's a biased opinion, but it's truly the most minimal invasive of all orthopedic procedures.
It's a very practical opinion, not a biased one.
Sir, I know this is going to be a very long question and a difficult one given the time, but there is a question that we have. What is the ideal entry point for the nail?
So if I go back to my slide, just to highlight this point, there is nothing ideal. You are asking a question that what is the ideal joke that will keep everyone happy? So this is the landmark, and so this is the question in mind. What is ideal? मैं ऐसा joke सुनाऊं जो सब हंसे, कोई भी ना रोए. It is not possible in the real world. So the idea is, like I said to the audience again, choose your nail, whichever you have, put it on the top of the shaft like I have shown here. So it will give you the correct entry point for the nail that you have chosen for that patient you intend to use it in. And humans will make error. We will make error. So make an error more on the medial side. If you have to make an error, if God gives you a chance that have to leave a varus deformity or a valgus deformity at a fracture. If God gave you that choice, you have to make a choice. You can't say, no, I want perfection. If God gave you a choice, no orthopedic surgeon should ever say varus. They will always say valgus. So similarly, if God gave you a choice here, you must say medial, not lateral.
Thank you, sir.
One last question, if we
Yes.
can. I'll shorten my talk and listen to Ritabh instead. Dr. Ritabh and as well as Mukesh sir, what is your view regarding the lateral cortex, which previously was considered in 2003 and 5 to be the most important structure in the intertrochanteric fractures? And now there are people who use a nail along with a plate to preserve the lateral cortex as well. So I just want to know if you are using them, or what's your opinion, if not, regarding usage of a dual implant because of the lateral cortex shattering or not present there. A lot of things have been going on in the world right now regarding this, especially in our part of the world.
Thank you, Dr. Trikha. In my practice, if I see a lateral wall combination, I always take my nail will replace it. And for me, it has no meaning. Once you put the nail, the lateral wall is already taken care. So if there is a combination, I have never used any plate so far. And if I tell you that I have no failure, it will be very difficult to digest. But I tell you really, I have never seen any failure. If you have done a proper reduction, especially your entry point has to be very, very good, especially in the subtop extension. If your Ritabh has rightly said that entry point is one of the most key point. And for me, the entry point has to be more medial, little medial. So the word eccentric is not the right word for these nails. And that is the reason we have more complication because of eccentric. Our nail should be more close to the medial side rather than eccentric. It should be absolutely in the line of the axis, like we use the piriformis fossa. It just little away from it is the right choice of the entry point. So for me, the lateral wall is not very important. But yes, there are a lot of people, they're using the plates, etc. But I have never used.
Ritabh sir, your view, sir?
Yes. So in my view, suppose I compare a nail and a DHS. So the DHS is lying outside the bone on the lateral wall, and the nail is lying inside the medullary canal. So what a nail does is basically working like a lateral wall, but it is within the line of the medullary canal. So it technically acts as a lateral wall and making the status of the lateral wall redundant. But to answer Vivek's question specifically, sometimes the GT has also pulled off. So despite the device, nail and lag screw device holding the two main fragments, the head and the shaft, the GT with its abductor mechanism remains deficient or may become inadequate. So if we feel that there is a problem here, now this fragment may not hold on. So then Vivek, to reduce our embarrassment, earlier I used to use a tension band wiring.
Ethibond.
Now I use Ethibond.
Yes, I know.
Many sir, your comments on use of a plate in proximal femur fractures along with a nail. Lalit, Mani sir.
Yeah, I am again not in favor of actually not used it. Like Dr. Mukesh Jain said, that once we have the nail there, we are not very much concerned about the lateral wall. So that's where the nail is helping me.
Dr. Trikha, what is your take?
No, because I have never used it in my life, but as Ritabh said, yes, I have used for abductors.
That's fine.
But I see it all around our country, so that's why I wanted to know what's the opinion of two of the experts out.
We are not using it.
Vivek, sorry, Vivek के question के answer में what I've seen, अभी भी जो sorry, the proximal femur nail which is being used is the 2 screw independent screw device. So there the purchase of the single 8 mm screw may not be as robust as the lag screw that we have for the proximal femur nail. So there the tentativeness of the surgeon may be making them rely on putting a plate also.
Okay. Valid.
Thank you, Ritabh sir. With the first two talks, I think Dr. Mukesh Jain sir and Ritabh sir have given their talks like magicians, and they have cleared almost all our doubts regarding neck femur fractures and intertrochanteric fractures, and have given a lot of tips and tricks given their vast experience in the field of trauma orthopedics. Moving from them, I go on to Professor Vivek Trikha, who has been my mentor, guide, my guru, who has taught me almost everything that I know in trauma. And I am lucky to be working with him. And he would be talking on a very difficult topic, femoral head fractures and how to manage these fractures in patients. Sir.
Okay. Thank you, Dr. Samarth, for your kind introduction. Thank you, DOA, Dr. Vash, and Dr. Shekhar for giving me this opportunity. It's femoral head fractures and how do we manage it? After the talk on neck femur as well as IT, which is the commonest fractures that we deal with in our practice, this is slightly a rare fracture, which we may not be dealing with every day. But just to complete the picture around hip, this is an essential thing. And that's what we will be discussing out here. It's around about that 5 to 15% of all the hip dislocations that we take care might be associated with this hip fracture. But nowadays, compared to the previous settings, I would say that we have been getting a lot of cases of these hip fractures as well for us. I'll just like to give the details regarding, I'm taking care of the Pipkin's classification and not the other classifications, because I feel that gives us a lot of information regarding most of the fracture patterns that we deal with and such. And it's a very easy one to remember. The Pipkin's one is the inferior fractures, which are there to the fovea centralis. The Pipkin's 2 is the one which extends superior or in the front of the fovea centralis. Type 3 are the ones which have Pipkin's fracture associated with a neck fracture as well. And type 4 is which is having a Pipkin's along with an acetabular fracture. Usually they are type 1 or 2 type. So first of all, once we have looked at a patient who is having a Pipkin's fracture, and we have got a CT scan done to visualize which sort of fracture is it, then we look at the prognostic value. And if we look at the prognosis, it is found that type 3 has got the worst prognosis, which involves the neck femur as well as a Pipkin's head fracture. Then comes type 4, which is again an acetabular along with Pipkin's. So combined fractures have got worse prognosis or a bad prognosis, whereas the isolated fractures of femoral head like Pipkin's 2 or Pipkin's 1 have got better prognosis. And best is of the inferior variety or the type 1 of Pipkin's, which gives us better results, because most of these fractures, as we know, this is inferior, so it is not involving the superior weight-bearing dome of the thing. So the decision making of what to do when we have a Pipkin's and if we have reduced it or not reduced it, or the hip is dislocated or not, is dependent upon the size of the fragment, where exactly it's located, the comminution which is there. Sometimes you have fractures which are so much comminuted that you cannot do anything right now with them. and also the displacements of the fragment. Can we do a non-operative treatment for a reduced Pipkin's femoral heads fracture? Yes, there are evidence and literature which suggests that you can do that, provided it's infrafoveal and anatomically reduced. So you need to take care that it is anatomically reduced, which is less than 2 millimeters in CT scan, and you need to get serial radiographs to see if it is displacing. And that's what makes it very subjective, because you look at the CT axial sections for the reliability, and then you are getting the radiographs which may not be so reliable. Operative interventions, if you are going in, the smaller fragments which may not be fixed or cannot be fixed can easily be excised. The large fragments have to be fixed anatomically. Usually you do the definitive fixation with the interfragmentary screws, which most likely and mostly used right nowadays are the headless screws. And the options, as I've written down, are the countersunk lag screws, headless compression screws, and people are also using bioabsorbable screws for them. Where do we and how do we fix them? Surgical approach. The two most common are anterior or posterior ones. The interior is the Smith-Peterson, or the shorter version, which is the Huter approach. Trochanteric flip osteotomy, which can be done in a lateral from the posterior side or the lateral side. And some people have still been using the KL approach. So first thing first, using a KL approach is not so practically beneficial for the patient, though it appears that we will be able to see and reduce it the easiest if it is dislocated. Because mostly the fragments are anterior and medial, and it is very difficult to visualize them when you are going from the KL approach or the Cocker-Langenbeck approach. Yes, the benefit from going posterior is that dislocated head can be reduced, but fixation of the anterior fracture is better if you go from the anterior side by trochanteric flip or by Smith-Peterson. This should be noted by people who are using the Cocker-Langenbeck approach for the fixation of Pipkin's fracture, that the chances of avascular necrosis is considered to be 3.2 times higher than an anterior Smith-Peterson approach if a Cocker-Langenbeck approach is being used, which means that you cut the short rotators and the piriformis and dislocate your head posteriorly to visualize the fragment and then fixing it with screw. And this is from the paper by Stannard, which was given around 20 years back. Hence, scale approach is not used. The interior approaches are usually used. The two main things which we have to look for when to use anterior is if the fragment is anterior first. The second thing, if it is can be seen easily. The third thing, the patient is not having a posterior acetabular fracture. And most importantly, the head is reduced. If you have been able to relocate the head inside the acetabulum, then it is easier to do it from the Smith-Peterson approach, which is an internervous plane or a Huter approach, which people nowadays are using for direct anterior approach as an acetabulum or in arthroplasty, which is now becoming and gaining prominence. So I'll just give you this place by saying that it is dislocated, but it has been now reduced. So after reduction, we have got, you can see it is dislocated right now. And if it would have remained dislocated, I would have used a different approach. But since it was reduced, we were able to bring the head back. And now we find that the head is lying eccentrically and totally rounded and 180 degrees turned. Then you go in from the anterior side. You go in between the sartorius and the tensor fascia, and through the Huter approach, you can directly access this place as I have shown by the markings. And this is what was done. And you can see that from the Smith-Peterson or the Huter approach, you can easily fix the fragment because all the entire femoral head can be seen right in front of you, and you just need to fix it. The reduction is not so difficult. It's the approach which is the difficult thing for such fractures, because if you see a 360 degree of your spherical head, you can easily fix the femoral fragment if it is big enough. That's the immediate post-op, and then you have the follow-up of it. Another case, 28 years old. Here the head appears to be dislocated. in the CT scan. But later on, when we have been able to reduce it intraoperatively also, we went anteriorly and we did the Smith-Peterson to fix this approach. What if in a dislocated head, which is not getting reduced, you go anteriorly? That is the question many people ask. So the thing is that sometimes your femoral head with a fracture can be buttonholed between the piriformis and obturator. And that's why if it is buttonholed from anterior Smith-Peterson, you will not be able to reduce your dislocated head. So preferably, then you will have to go posteriorly, maybe do a tenotomy, which can be sutured back, and then you do a trochanteric flip. And that's the patient's follow-up, having good amount of good results with this. So there is good amount of evidence for Smith-Peterson approach. It is a very short timing, improved visualization. As I've shown you, you can see the exact full 360 degrees. However, there is a chance of anterior heterotrophic ossification because you are going in between the gluteus as well as the rectus out there. Then this is the paper, which has been one of the biggest papers by Chip Rout and from Seattle, where they have fixed nearly 164 fractures. And they said that anterior approach is a major approach which can be used for fragment fixation as well as for mini fragment screws. Then we come to the second approach. In femoral head, it's mostly the approaches, which is the common thing to note, and how we are going to fix them. Trochanteric flip is being prescribed and given by Reinhold Gans, where the femoral head is again dislocated anteriorly to give good fixation. And he was able to give it in 2015 in CORR that it is a reliable approach for treatment of femoral head fractures, and it gives comparable results as compared to the anterior Hutter approach. Even we have our paper in Hip International, where we have shown our trochanteric flip osteotomy results, which have been quite good, and we have been having no problems, any of sorts, associated with trochanteric flip osteotomy. So I'll just show you a dislocated hip and a Pipkins, one in a 70-year-old male. Since it is dislocated, you go through the trochanteric flip. You can see that the trochanter out here has been flipped. You have cut a digastric osteotomy has been done. And you can clearly see the fracture line, which has been properly reduced. You get again a 360-degree view. As I said, the approach to a hip joint or a femoral head is anterior. Whenever you have to see or visualize your femoral head, you have to go anterior, be it through Smith-Peterson or trochanteric flip osteotomy, and then you go anterior. And that was done. And you can see it's a 5-year. Now it's around 8 years follow-up I have of this patient. He has other problems in the distal femur, which has still not recovered well. He has mild infection, but this hip has given him no problem in spite of 70 years. And now he's quite old, in early 80s or late 70s. Another case, you can see the dislocation. Here you can see that the hip is lying posterior to the wall. And many of these are buttonholed between the two tendons, which cannot be taken out from the anterior side. Hence, you need to go about looking at that fracture, going from the trochanteric flip, doing the tenotomy piriformis and the obturator, and then you remove the buttonholing, reduce the fracture, and then dislocate it anteriorly. Because why to dislocate it anteriorly is that you will not get a proper view of this fragment completely in a KL approach. If you do that, most of your screws are going to go from the edge of the fracture and not fixing it at the center of that epicenter of this hemisphere. And this is what, after 3 years, the trochanteric flip is giving us the results. Pipkins 2 is difficult. It is anterior. As you can see, this is an anterior fracture and very bad to look at. But once you reduce it with trochanteric flip, you still can get good results and good picture with them. Pipkins 3, or the worst prognosis, is having a neck femur also associated with it. This is one of the fractures. You can see that fracture having sort of a neck femur along with the Pipkins fracture, which we had fixed. We tried to fix it after reduction. You can see that the trochanteric flip was done. We reduced it completely, and then we were able to fix it. However, Within 6 months or so, it failed, and we had to subsequently go in for a total hip replacement. And this patient, we have done quite a rare fracture, Pipkins 3, but most of them nowadays, whatever we have done and the worldwide also, the results of these are very poor considering the fracture, which is neck as well as the head. If you see in this one of the big papers, 164 cases, all cases of Pipkins 3 failed in their hands as well, who have done one of the maximum numbers of femoral head fracture fixations. Coming to Pipkins 4, which is having an acetabular fracture also associated. Here you can see there is a wall fracture with a dislocation, and such fractures can be fixed obviously from the back side, because then you fix the posterior wall also along with them, and you fix the screw or the trochanteric flip, you fix the anterior femoral head fracture as well. That's the fracture with follow-up having good results as expected in such fractures. So I'll just conclude that there are two main things which we need to look for. In femoral head, they're not so common, but when they come, the biggest dilemma is where to approach them from, anterior or posterior. We always go from anterior when it is reduced and the fracture is anterior, be it superior or inferior. Type 1, 2, and 4 have got still better prognosis, but type 3 is the one which has not fared good in most of the hands, in most of the patients. Intervention is usually through HCS, headless screws, or through countersunk 3-5 screws. Approach I have already discussed in detail. Anterior and trochanteric flip are used. If it is dislocated, which is not reducible femoral head, I would request you to go posteriorly, because if you go anteriorly, you might burn your fingers, because you will just see an empty femoral acetabulum, the head lying posteriorly. You cannot reduce it because the buttonholing is there, and you cannot even cut it without seeing the structures. Thank you very much for your hearing.
Thank you, Vivek sir, for making such a difficult topic look so simple, and in beautifully explaining how to select the approach in these complex fractures, when to go anterior and when to go posterior, which is the major question coming from delegates. Sir, one question is, earlier the headless screws were only available in 2.4 and 2.7 millimeter sizes. But now in the market, we have 4 mm, 5 mm, and 3 mm headless screws also available in longer lengths than 32, because some of the femoral heads are 40, 45, 46. So what is your take on the choice of fixation that you would now use for fixation of femoral head fractures?
For me, the fixation depends upon the size of that fragment I'm dealing with. Many a times the fragment is very big, but it is very flaky. It doesn't have a big subchondral bone. So until unless there is a good subchondral bone with at least 1 square centimeter of that fracture fragment, then only I will be going in for a screw which size is more than 3.5 or 3.5. Because remember, 3.5 screws, even if it is headless or if it is with head, you are going to countersink it. So countersinking those flakes many a times becomes difficult with a big screw and it breaks. So for me, still 3.5 screws sometimes, and 2.5 screws are good enough. Really, actually what you want to do is just fix this fracture. It is inside a component. It is a very big, good, well blocked socket. So once you reduce it and it's fixed with good amount and your vascularity is maintained by your approach, it is bound to unite earlier. So you do not require such a stable fixation so as to get 3.65 screws or 2 screws, 6.5 screws. You can get away by 3.5 screws, and even smaller screws of 30, 32 also. We have been fixing most of my fractures with 32 right now, and but we put in 2 or 3 screws, at least 3 screws if possible. You have seen that triangle which we make, fixing it all around, not only eccentrically, and that gives us good results.
Thank you, sir. I think Dr. Ravi has a question.
Good evening, sir. So it was an excellent presentation. Sir, seeing to the complications of type 3 fractures, as you have mentioned, and in almost all the hands, so what are your tips for those on the basis on your experience? Actually, what should we
first of all, refer it to your good friend. That's the first tip I'll give it to you. I have given it to Samarth sometime. He remembers that. No, we have done it together. And what we have done is, I have taken, it's a very rare thing, very rare neck fracture with a femoral head fracture. In a high volume case and a center like ours, I have seen in my 20 years career, 4 or 5 cases of them till now. And out of them, 4, I tried my hands, burned them within 6 months. And in one, which Samarth knows about, we straight away went for total hip. The question is, most of these patients are young, 24, 20 to 25 years. And it burns your heart as well when you are trying to do and offer them total hip right in the beginning, when you have the technique and the thing to fix them as well. I have seen in the world only one person and one good result. There might be more, where they have used the fixation for the femoral neck has been used very properly. And maybe with FNS, some people, and with results which Dr. Mukesh has shown, maybe we might be able to use them with that also. But they used an anteromedial plate also to reduce for the neck and get a better fixation for the neck fracture. So I saw it from Stanford University, one of the 2 cases, because I discussed it with the paper which I have shown you, the biggest by Chip Rout and Reza Firozabadi from Seattle. And even their cases, when I discussed with him, he said they many a times are going in straight away nowadays for total hip. So better not to have them. If yes, you try your best, but I will feel in my 4 cases which I had, I still feel my fixation for the neck was not that stable, because I was opening it up and doing it in trochanteric flip. So obvious choice was cancellous screws. But maybe I should have used an anteromedial as well and tried. I'll still want to, in my heart, try it, not to give him a total hip straight away.
So, sir, I will reframe this question in another way, and this will be for you, Mukesh sir, and Ritabh sir. So, a situation with a type 3 fracture, Pipkin 3, in a 25-year-old, in a 50-year-old, and in a 75-year-old. So, Vivek sir has clearly told in a 75-year-old, he would probably prefer a hemi replacement or a total replacement, depending on the needs of the patient. So, given all, we have so much of experience here, given all your experience and the literature available, for a 25-year-old, would you still try fixation or directly go for a total hip? And for a 50-year-old, whether you would try fixation or go for a total hip, sir? Vivek sir first.
You know that I told you that I have done a replacement, the last one which we did in 2020 March, 2020 February. It was a total hip. But now with the advent of newer fixation techniques for neck femur, I might still again give a try. But the most important thing is counseling of the patient, that he might have a failure. If he's willing for it, I'll go for a total hip. But for a 25-year-old, I feel that we should be giving it a chance, because if your type 1 Pipkins is there along with neck femur, we might be able to salvage it. It will be worthwhile. That's the only take which I can say.
Mukesh sir, your take?
See, kind of my practice is I'm straightforward to go for THR. Nothing in between.
Ritabh sir?
I mean, we cannot try.
Ritabh sir, your take, 25-year-old and 50-year-old with type 3 Pipkins. Type 3 Pipkins is the type which has a type 2 Pipkins component rather than a type 1 component.
Put things in perspective, I stay in Delhi. I'm in private practice. If I get someone like this, I always will have the luxury of choice to refer him to my best friend.
I know.
So if there is someone who can give the patient 5% better, 3% better than me, I will have no hesitation in referring this patient to Vivek. Counseling that even he's not God, but the chances are better there. Now, if the patient decides to stick with me, I will do my best to preserve the hip.
Thank you, sir. Thank you, sir.
At 25 or 50, at 75, obviously, you can't give surgery again and again. So there, hip replacement would be the first choice.
Any other questions for Vivek, sir? I think in all the 3 talks, everything has been so beautifully covered that, they have made very difficult things look so simple, given their vast experience, their skills, and the presentations that they have made. So going on from the 3 talks, we go on to Dr. Sandeep Yadav, who is a assistant professor in Mahatma Gandhi Medical College. He comes with a huge experience from PGI Chandigarh and AIIMS New Delhi. And he does a lot of work in pelvic-acetabular trauma as well as complex fractures. So Dr. Sandeep, can you please share your case?
Good evening, everyone. Respected all teachers, DOA members, Dr. Samarth. After all the wonderful lectures, I will present a case which we have discussed in Trikha sir's lectures. So I will start. We had a patient, 20 years old, with history of road traffic accident, pain in the right hip, inability to bear. Patient was hemodynamical and came to us 48 hours of the injury. Short right lower limb, dorsiflexion was absent, and no other visceral injuries there. So we have X-ray of the pelvic body, and this was the X-ray of that patient, the 22-year-old male with and you can see that the is located posteriorly, and one fragment of the head is inside the stub. So how to proceed for this? So first, any further investigations in the CT scan, MRI, or as dorsiflexion for studies. We have ordered CT scan with reconstruction, and this is a 3D CT. We can see that.
I think we have lost Dr. Sandeep due to connectivity issues. Dr. Nishank, would you be, I think we have him back now, Dr. Sandeep. So, Mukesh sir, about Dr. Sandeep's case, he's asking about further investigations. So,
I think CT scan is the only thing which we need at the moment, nothing else.
Dr. Sandeep, do we have a CT scan for the patient?
Yes, sir.
Okay. So if you have connectivity issues, you can turn off your video. That might improve. Yeah, okay.
So this is the CT. Here you can see that one of that fragment is lying posteriorly, and remaining one fragment is lying into the acetabulum, and rest is the femoral neck. So this is 2D cuts. We can see that the head fragment is lying posteriorly. So basically, diagnosis is 22-year-old male with right-sided fracture femoral head, Whipkins type 3 with dislocation with sciatic nerve palsy.
Okay, Dr. Sandeep,
So
I think
as we have discussed it, Trikha sir has told it.
This needs a posterior approach. So Dr. Vivek has made your job really easy, and it is easy now. So we need a trochanteric flip for this patient, I think, from the last talk. That is something that we have discussed. And we have also discussed the options of total hip arthroplasty, hemi-arthroplasty, and fixation. So if we can go ahead and see what you have done.
Thank you, Dr. Samarth. So osteosynthesis, these are the approaches we have. So we have chosen Coker-Langenbeck approach, and you see that the fragment is lying posteriorly. So we should go posteriorly for this, and the smaller fragment of the head attached with the ligamentum teres, which we have retrieved from the joint, and we have make two fragments as a single piece. First, by using the Herbert screw and fix it, and then after making it a single head fragment, then we have fixed it with the neck part. First, we have put a Herbert screw from head to neck in a retrograde fashion, and then we put 3 6.5 cc screw from the trochanter to head region, and there was a labral tear from 12 o'clock to 5 o'clock position, which we have repaired with using ethibond. So this is the sciatic nerve which was found very contused. So sciatic nerve decompression was done. So this was the post-op X-ray, AP view and lateral view. Any comments on the post-op X-ray and surgical approach?
Vivek sir, any comments, sir?
Nicely reduced and nicely fixed as well. The thing is that for me, I would have gone with a trochanteric flip as well. But yes, it is easier to do it if your neck is totally fractured, to fix it with a Herbert screw first and then do it. The reduction is good. Just keep your fingers crossed and hope for the best. That's the thing in my experience. So let's keep it and let's hope that it goes well.
So I think this was a type 3. Mukesh sir, we have already discussed that he would probably go in for a replacement. So Ritabh sir, if you were to fix this fracture, would you have done anything differently? Vivek sir would have done a Cocker-Langenbeck approach with a osteotomy. But other than that, with regards to fixation, would you have done anything differently?
Rather than using 3 cannulated cancellous screws, I may have gone for a more angular stable implants. I may have opted for a DHS to give compression across the fracture.
Sir, I think he has operated in the lateral position. So would you have done a DHS in the lateral position, sir?
Yes.
Okay, sir. And
everything is there in front of you. The approach is there. So why not put a DHS? Okay. So we've done a good job on the head, but probably reduced our surgical temperament by the time fatigue sets in. So let's rely on 3 screws. So the screws are already not compressing the fracture. The fracture line is visible and the screws are backing out. Yes, we have literature evidence to say that things may not work out well keeping your fingers crossed. But yeah, I may have used an angular stable implant here.
So I also have a comment.
Sir, I have one question about DHS.
Right.
Yes.
Sir, we have put 3 Herbert screw into the head. So is there any possibility to put a DHS because our Herbert screw comes in the way of our DHS blade?
Not necessarily. The DHS lag screw has a 22 millimeter thread length. So yes, the head merits priority, but we could have tried a DHS. So I don't think the screws may have interfered. There's a lot of way. If the 3 cannulated cancellous screws can go in of 6.5, so 6.5 into 6.5 into 6.5, so it's already a 20 mm thread diameter in the head. So a DHS screw may have also gone in.
I think after Mukesh sir's talk today, there is another option of using a FNS here in this patient, which is a angle stable construct. My comment is, Dr. Sandeep, you are lucky to have such long HCS that you have put from the head onto the neck, which is not available with everyone. Everyone is not so lucky. And the other comment that I have to make here is your screws, the thread, you have used a partially threaded screws, but I see at least 1 screw, at least 2 screws out of these 3 have threads across the fracture rather than going beyond the fracture. Probably the reason I think that the compression that Ritabh sir is talking about has not happened intraoperatively. But your reduction, your head reduction, neck reduction looks
yes, sir.
Brilliant.
It's absolutely good.
Yes, sir. Because I have put 1 Herbert screw first in the retrograde fashion. So one was of the not achieving the compression is because of that Herbert screw. And second thing is my 6.5 cc screw are touching that Herbert screw and they are not going inside. So they are preventing that compression. That may be the cause, sir. And I find that difficulty during surgery.
Right. Very well done.
So,
Atul sir, your comments, please.
Placement of the screws definitely plays an important role in this case. I feel that compression, this Hubbard screw which they have put, the long one. Before that, that's the 3 screws which they have put. Can one go into the inferior part, inferior half of it? And like you said, that screws could have been slightly longer also.
Thank you, sir. Dr. Ankit, do you have any
Compression at
comments?
the fracture site is definitely because of these 2 screws, the threads passing through the fracture only. Otherwise, it would have compressed, I think.
Thank you, sir. Dr. Ankit, do you have any comments?
Yes, just that these screws are in the fracture site, possibly leading to a lack of compression here. Otherwise, the fixation and reduction looks quite apt. Just that the neck would have been, better reduced had the threads been across the fracture with the smooth part crossing the fracture.
Thank you, Dr. Ankit. Dr. Sandeep, so let's see what is the result.
Yeah. So post-op rehab was, we have applied skin traction for 2 to 3 weeks, isometric quadriceps exercises, and for sciatic nerve palsy, AFO was given, and nerve conduction studies 3 weeks. This was the 9-month follow-up of this patient. The X-ray was taken last month on 5th of Feb, and it was almost 9 months. Any comments on this 9 months follow-up?
Looks to be writing, sir.
Vivek, sir.
That's a great fixation as well as great result till 9 months. I would say that you just be cautious, because my failures have been after union till 2 years. So I can already see that there is a joint space which has started reducing, and there appears to be some sclerosis. So just watch it, because it appears till 9 months or 10 months. I have had burnt my hands. So I'll just like to caution, but till now, excellent.
This is the video running, but actually patient walking pain free. He is using a cane, and the sciatic nerve is completely recovered. That is the best part. And so far patient is not having much of the problem. He is a primary school teacher, and he has joined his duty and he is doing his routine activity. So this is 9 months follow-up, and let's hope for the best, how far it will go.
Thank you, Dr. Sandeep.
Any further comments for improvement? And sir,
thank you, Dr. Sandeep.
Dr. Mukesh, would
should
you
we proceed for next case, or
Dr. Sandeep, so we'll go to the next speaker. Thank you for that wonderful case. We had a lot of discussion on a Pipkin type 3, and you presented a Pipkin type 3, which seems to be having a great result at 9 months follow-up. A very nice case, a very rare case indeed. Thank you for that. Dr. Ravi, do we have time to take another case?
Yeah, please go ahead. Please go ahead. And Dr. Samarth, one more thing. Dr. Vivek sir was about to make some comment, I think.
Vivek sir, sorry.
It was just to ask Dr. Mukesh, after seeing the good result, would you change your practice now, or it will still be a replacement?
No, I will not.
Okay.
I will still continue with the.
Okay, fine.
Okay.
Because this case has at least given me hope that I should not go in for a total hip stay in my hospital as I had gone in the last case. Maybe we can still improve.
You can wait for 2 years and send him to me.
Okay.
So with this, thank you, Dr. Sandeep. We will move on to the next case. If you can stop screen sharing, please. We'll move on to Dr. Nishank Mehta.
Thank you, sir. Thank you so much.
Dr. Sandeep, if you can stop sharing the screen, please.
Yeah.
Mehak, can you stop the sharing? Samarth, you can also stop sharing.
I have stopped it.
Thank you, Dr. Sandeep. Dr. Nishank, if you can please put up your case. Dr. Nishank.
Dr. Nishank, are you there?
So,
By then, Dr. Samarth, you can go ahead with your case.
okay. So I think Dr. Nishank is having some network errors. So I will try to show a case. So though this is a case of a 44-year-old. Can you see the case?
Your screen is visible.
Please go ahead. Please go ahead.
44-year-old female who had a road traffic accident. She was a pedestrian hit by a four-wheeler. She suffered a right subtrochanteric fracture and underwent ORIF using DCS in December of 2013. I'm sorry, I don't have the preoperative X-ray. This is the X-ray that she had. So in March of 2014. This is not the time that the patient has presented to me as yet. So I'll go ahead before I take any opinion. So this is March 2014. The patient came with this. She was operated in December 2013. So going to the panel, what is the options that we have? Mukesh sir.
Can you go back to show me the X-ray? Yeah. You see, it's a failure because of the poor biology. And I feel that I will just remove it. I'm not going to wait at all. And I'm going to do a 95-degree plate and plate with a longer plate and with the compression and bone grafting. That will be my choice rather than putting a nail.
Thank you, sir. Ritabh sir.
Yes, I would remove this implant. This is now, the implant is in its plastic range. It hasn't broken, but it has bent. So there is no point in waiting. So we have to revise this. My choice would be to remove the device and do a nailing and bone grafting.
Sameer sir. Okay. So
am I audible, Samarth?
Yes, sir.
Okay, as I said, of course, this is an extreme. Whereas the mechanical axis is all disturbed. So I think this needs removal and correction but I would say this would need some osteotomy, a corrective osteotomy, a valgus osteotomy, to align the mechanical axis, and then maybe, of course, a nailing maybe. But I don't know about the hip. How's the hip now? Did we get some CT or etc. to see the hip joint?
The hip joint is okay, sir.
Okay, so we are only talking of a malunited fracture. So I think a osteotomy and maybe a nail, and definitely a removal, and no point in waiting further.
Okay, so I'll go ahead. So this patient has still not come to us. This is July 2014. She was first operated in December. Then in March, she was about to fail, and in July, this surgery was done. And then so I'll go back to this step. I don't have good X-rays because this is what the patient had. And then this is in Feb 2016. Ritabh sir.
Yes, so a fracture line.
So you wanted to remove the DCS and do a nail. So this is what someone did.
Yes.
And this is 6 months down the line after a nail.
Not 6, April 16, April 14.
2 years, sir. Almost 1.5 years.
So 1.5 years. So nail has given longer time for the bone to unite.
Sweet.
But I believe that the fracture line is still visible, and this nail is in a static mode. So I see bone grafting must have been done. The nail has given longer time. So the problem is still that the biology is taking time to catch up. I don't see any sign of failure. This probably is the fixation as of July 14 also. So what does the patient have?
Pain and difficult inability to walk, sir.
Pain and inability to walk. Okay, so the device is failing. And we don't have the distal end. So probably
the distal end is dynamized, sir. The screws are broken distally.
The screws are broken. So there is now rotational instability. So that's the reason for the discomfort. So this needs mechanical stability.
So would you want to renail this patient, sir?
Yes.
Mukesh, sir?
Again, same, back to same square one, 95 degree.
Vivek, sir, I know that you know about this case, hence I'm not asking you many questions, but if you did not know about this case and this is what she presented to you in February 2016.
Right. So I'll just like to highlight 2 points, which Ritabh also pointed, and that's my point as well, which I point always. That plate failed immediately when there was lack of medial support. Nail gave you better for 2.5 years or roughly 1.5 years. It let it remain there because it was more internal intramedullary implant. So it did not fail, though it was not done properly as it should have been. Hence the question again comes, reduction, improper technique has no excuse. So you cannot get it. What Nail has done is it has consolidated all those comminuted fragments to a better place. And now there is sort of a single fracture line which is happening. And that later on with the, as it has been said, the backing out, it is going to fail, which appears. But as you know, I would have gone with an angle blade plate and would have fixed it with an articulating tension device on the lower side and getting the best maximum compression right in the beginning. And as Mukesh sir would agree that it is one of the best implants and the cheapest implants which anybody has designed for orthopedics.
Dr. Sandeep, your take? Dr. Sandeep Yadav?
Samarth, can I ask one question from Dr. Vivek and Dr. Mukesh?
Yes, sir. Please, sir.
With this angle blade plate, sir, will you be doing grafting at this stage also?
Yes, definitely, sir.
Okay.
Sir, so this is
slight correction of valgus or the varus with an osteotomy which has been done, and you just do it. That itself will be a good amount of bone graft, and the compression will be achieved, and with an articulating tension, you can do that.
I think articular tension is very important to put a compression as much as possible. You can't put with the eccentric screws.
Yes.
So for non-union, you need a older device, which we are not using nowadays. But I think we should remember 95 degrees is one of the best implant till date from AO. I can say that.
So this is March 2016. So everyone said this is failing, and this has now failed. The nail has broken. And I think the opinion will still remain the same, whether it was broken or not broken. And this is another view from March 2016. And this is April 2016 when it has, patient has did not consent for surgery in March. So this is April 2016 when she consented for a surgery. So now I think all these options are already discussed. So what we did is went in, took out the screw, took out the nail from the top, reamed the canal, cleaned the fracture ends, took a long fibula. After correcting the varus, I reamed the proximal fragment in valgus and then put in this fibula, which acted as a strut to maintain my valgus throughout the surgery. Then used a proximal femur locking plate. This case was done way back in 2016. If I were to do this case again today, I would probably use a nail, but this is 2016. And this is a good plate, very strong plate that was used. Getting the valgus right, putting in bone graft, putting in a long fibular strut graft, and so after taking proximal hold, using compression at the bottom, using the jig. So I did not open much of it, only the fracture site and the proximal fragment was open, not a very big incision. This is a MIS system with this plate, use these long sleeves with the MIS system, got the compression right, put in these screws, and got this reduction intraoperatively. That is the post-operative X-ray. Any comments, sir? Ritabh, sir?
Well done. But were we able to get that compression which we are all talking about across the fracture with this MIS system?
Sir, so I have not opened the shaft, but at the bottom I have opened to get that compression, sir. And intraoperatively, the fracture site is open. I have compressed as much as I can. And rest of it, I have filled a lot of corticocancellous bone graft along with this fibula.
Right. So the fibula strut has enhanced the hold of the device in the proximal fragment. It has, it will give a longer time to the plate to help the bone unite. You've augmented the biology.
Mukesh, sir, your comment, sir?
This is another way of treatment. You have done a wonderful job, but I still prefer a 95-degree because I can give a better compression.
Any other comments? Vivek, sir?
You also, you will be listening to this quite often. If you are going to get good results with this, if I assume that in this case, why would you shift to a nail now?
Sir,
what was the thing which you were not able to achieve with this, which you would do with the nail in a subtrochanteric fracture now?
Sir, like you have said that this plate will give me, if this was not to unite, then this plate would probably give me a shorter time to fail than a nail. So that race between implant failure and union, so just a longer time for union and a longer time for implant failure it will give. So probably the reason. And the other thing is a nailing would be, for me, would be a much shorter procedure with much less blood loss and lesser surgical time. So that is the reason why I would probably 7 years down the line from when I did this, I would now nail this probably. But I think I'm quite happy with what I had done back then. And if there was some reason I could not nail this, I would have probably even today, I would keep a plate as a backup.
Yeah, I would just say that your intramedullary fibular strut is giving you that partial effect of your nail, which you wanted, along with an extramedullary implant. So it's a combination of implants, both biological as well as metallic, which you are used, which is here, which has given you, which might give you the good results.
Can I say something?
Yes, sir. Yes, sir. Yes, sir.
So what system did you use? Can you repeat it, please?
Sir, this is
what
Smith and Nephew.
Plate or, yeah.
This is a Smith and Nephew plate, sir.
Okay, so I think it's very nicely done. The strut graft is working very well. I can't think anything else could have been done in this. But my question to the panelists would be: this is a very good and refined system. Affordability could be an issue. So my question would be: what else could we have done? An average orthopedic surgeon who wouldn't have this kind of armamentarium, or the patient could afford this much? What else could have been done here in place of this? So if somebody can, all of you can tell.
Sir, I think Mukesh sir and Vivek sir have said that angled blade plate, which is one of the cheapest device, would be one of the options here, in addition to a 95-degree DCS or something like that. Vivek sir and Mukesh sir have already commented on that, sir.
The plate you have used is also acting like a fixed angle blade plate. So I think the fixed angle blade plate, the cost effectiveness is more, but only it is technically demanding. So people are not very fortunate to use this. But those who are using this fixed angle blade plate, 95-degree, they are definitely having good results. This implant is also giving the same type of stable fixation with fixed angle blade plate.
Dr. Vash, I think it's time again that we, when I was a postgraduate, we used to do, this angle blade plates. Then, of course, came DHS and all others. I think it's time again that we start learning this again. Yes. And for the new surgeons, this is not workshops mein aajkal DCS angle blade plate nahi sikhaya jata. I think we should again go back to those times and learn all this again.
I fully agree.
Certainly.
Sir,
Next month in hip preservation, we are having this workshop
Yeah.
also.
That's nice.
just to finish off the case, so this was in 2016, and this is my last follow-up. I tried to reach her during COVID. I know it looks bent, but it is because the patient is holding the film. If you look at the thumb on the left side of the film, and that is why the film is actually bent. So the femur has not bent, and this shows 3.5, 4 years down the line, it has united well. The patient is completely asymptomatic, and that is her standing and having full knee and hip range of motion. And this is a happy patient. I thank you so much for patient hearing, sir.
Wonderful.
Good case.
Samir, sir, if you could. So I think we have reached the end of our webinar today with the great talks and a wonderful case from Dr. Sandeep Yadav. I thank everyone for logging in. I thank the faculty for accepting our invitation and giving such wonderful talks. Dr. Samir and Dr. Vesh, if you could just give a vote of thanks.
I think Dr. Vash would do the last. Let me thank you very much, Dr. Samarth, for being a perfect host and a moderator. No doubt we had the best here, the masters of trauma, and Dr. Mukesh Jain, with the big experience that he has of all those decades that he's been working. So thank you very much for talking on the latest techniques. Then, of course, nailing Dr. Ritabh. We've listened to him in many webinars and many workshops. And thank you, Dr. Ritabh, for again updating everything again. And Dr. Vivek Trikha, we all know he comes up with best ideas and what is the latest and what is in the cutting edge technology. Thank you, Dr. Vivek, again. And we really value presence of all of you stalwarts. Thank you very much. And thank you, Dr. Sandeep, for a lovely case presentation. Dr. Samarth, as always, I always feel कि जब भी मुझे डिफिकल्ट ट्रॉमा आता है, पता नहीं मुझे क्यों सामर्थ याद आ रहा है. मुझे लगता है कि सामर्थ से मैं जरूर पूछ लूं. बाकी लोग तो बिजी रहते हैं ना. सामर्थ इज अवेलेबल.
उसके बगैर हम सब असमर्थ हैं.
Absolutely. Well said, sir. Well said. And Nishant, thank you very much again. Thank you, everybody, for coming and taking out your weekend time, giving it to DOA, and really contributing to all of our knowledge in all of us. Thank you again. So over to Dr. Atul Vesh for the closing.
It's a really learning experience, and we enjoyed the session. Dr. Mukesh Jain, so nice of you, sir, to please join on this. And Dr. Vivek and Ritabh have been our regular faculty. I want to thank Dr. Ravi Chauhan for organizing this, our IT man. And also I want to thank the OrthoTV, who have been kind enough to give us this opportunity for live, and this will be on their website on the OrthoTV, this presentation for future generations and our young surgeons to learn about these three beautifully covered topics. Thank you so much, everyone who was involved on this CME. Thank you so much.
Thank you.
Thank you all.
Thank you, Dr. Ravi. Again, Dr. Atul ne kar diya, but you are the go-to guy. Thank you, Dr. Ravi, again, for conducting everything so smoothly. Thank you, Team DOA.
Thank you.
Thank you, sir. Thanks a lot.
Thank you, Dr. Bash, sir. Thank you very much.
Thank you, Samir. Thank you so much.
Thank you. Thank you.
Please.
ललित सर, डिनर हो गया?
चल रहा है अभी. मजा आ गया. Good session.
Mehak, are we live still?
No, I don't think so.
Mehak, are you there?
रवि, थोड़ा सा शुरू में टाइम मिलता है ना, हमें बाद में भी मिलना चाहिए.
नहीं, बाद में मिलता है.
एकदम से जाने का मन नहीं करता बिना बात करे सबको.
मैं एंड में जरूर टपक पड़ता हूँ.
सर मस्ट है एटलीस्ट. सर ये गप्पे थोड़ी ना शुरू और एंड की बड़ी इंपॉर्टेंट है मेरे ख्याल से.
हाँ.
बाकी इज बिजनेस.